Thank you for joining us. My name is Usha Tedrow, and I'm here with John Sapp, who's just presented the results of the VANISH2 trial, a really important clinical trial. John, could you tell me a little bit about the motivation for doing the study?
Absolutely. Ventricular tachycardia is a really terrible problem. It's the most common cause for sudden death, and it typically occurs about 15 years after a heart attack. When it occurs, unfortunately, the large majority of patients don't survive. Those that do survive get a defibrillator. And a defibrillator can protect them from recurrent episodes of ventricular tachycardia, but it doesn't prevent recurrences. So to prevent recurrences, we either have to use a drug like an antiarrhythmic drug or a procedure, a catheter ablation.
Absolutely. And can you tell us a little bit about the trial design and maybe a little bit briefly the results?
Sure. So the trial was designed to answer the question of whether we should be using ablation or antiarrhythmic drugs as first-line treatment for ventricular tachycardia when we feel we should suppress it. And we randomized 416 patients to receive either a drug therapy or a catheter ablation procedure. What we saw was we saw high event rates in both groups, but we saw a 25% reduction in the composite outcome of death, appropriate shocks from the defibrillator, slow VT that prompted the patient to go to the emergency room, or clusters of ventricular arrhythmias that had to be treated by the device. So that, we saw a 25% reduction in the rate with catheter ablation as opposed to antiarrhythmic drug therapy.
Absolutely, and I was impressed that there were actually some toxicities and intolerances of the antiarrhythmic drugs.
Yeah.
When we're in the office, we don't often consent people for antiarrhythmic drug use. What do you think about that, and what are the risks of the antiarrhythmic drugs?
It's a great question. Maybe I'll answer first about ablation, because the risk of ablation is kind of upfront, and we do specifically mention those risks when we talk to patients. The risk of antiarrhythmic drugs is spread a bit more over time. But we did see in the drug arm, we did see risk. So a small percentage of lung injury, a small percentage of liver injury, and a small percentage of thyroid injury, and some neurotoxicity as well. So all in all, around 10 or 20% of patients on drug ended up having to stop the drug because of side effects or intolerance.
Absolutely. And do you think that you had 2 drug strata, correct,
yes,
in this
that's
study?
Right, we did.
Do you think that one of the drugs was more effective than the other in preventing ventricular tachycardia recurrence?
Yeah, that's a great question. We designed the study so that sicker patients with worse heart failure and worse function of their heart either got ablation or the much stronger drug amiodarone. That drug has much more risk of side effects. Patients who are a little bit less unwell, with less severe arrhythmias and less severe heart disease, were randomized to a gentler drug, fewer side effects, also not as effective, sotalol or ablation.
And how were the results different than comparing ablation to drug in those 2 different strata?
So it wasn't a statistically significant difference, but I think maybe it's just underpowered to see the difference. We saw that the arrhythmia outcomes were a little bit better with ablation than amiodarone, but quite dramatically better with ablation than sotalol.
Yeah.
On the other hand, the side effects from drug were mostly, we think, in the amiodarone drug. We're going to have to do some sub-studies to really tease that out and figure out what's the actual risk benefit so that we can convey that to patients when we're decision making.
Yeah, absolutely. And when I was looking at the survival curves, it looked like for catheter ablation, maybe the success rate was around 65–70% at a year. Are there particular patients that didn't do well with catheter ablation? Maybe are there some patients that should get a drug and catheter ablation right from the get-go?
It's a good question. We couldn't identify any specific subgroup where drug looked clearly better than ablation. So all of the subgroup analyses that we did, nothing statistically stood out as showing that drug would be better than ablation for one particular group.
And could you maybe just tell us a little bit about, for like your clinical practice, how is this trial going to change how you look at your next patient with ischemic cardiomyopathy and VT?
Well, the thing I think it's going to change is, before it was very common practice to wait until drugs had failed before considering catheter ablation. I think the trial clearly shows that it's safe to consider it as a first-line treatment, and maybe it's a better treatment first line, or at least I think we now have a better assessment of when you're talking to a patient, you can really tell them, okay, here's what the effectiveness might be, but here are the risks. And then we can have a more meaningful conversation with the patient and make that decision on an individual basis.
Absolutely. Well, thanks so much, and congratulations on this fantastic trial. I think it's really going to influence the medical care for a lot of our patients.
Thank you very much.